Dr. Nanci Coppola is a private consultant in the areas of sexual risk avoidance and nonprofit governance. Since 2017, she has served as a senior technical advisor for risk avoidance to the Office of the U.S. Global AIDS Coordinator. From 2008 to 2016, she served as the Chief Executive Officer of Program Reach Incorporated, a nonprofit focused on youth development and sexual health organization. She has served as the project director on several federally funded adolescent sexual health education initiatives, including a 5-year Promoting Health Among Teens replication project, through the Office of Adolescent Health, U.S. Department of Health and Human Services. Coppola combines her medical training with an extensive background in teaching and curriculum development. She has vast experience in adolescent and reproductive health studies, including serving as the primary author of the Healthy Respect Youth Development and Character Development programs, which includes sexual risk avoidance programs for youth ages 9 to 19. Dr. Coppola is also a published author on topics related to sexual health education. She has authored numerous articles on programmatic success and outcomes. Most recently, her research on the impact of pre-implementation planning on program success and on the importance of cultural sensitivity in program delivery have been published in major peer-reviewed journals. Dr. Coppola's work in quality assurance and fidelity monitoring have garnered national attention. In addition to her medical and educational background, she holds a master's degree in community health administration and health education promotion. Dr. Coppola received her undergraduate training at the University of Rochester, where she received degrees in biology and psychology with distinction. Additionally, she holds a graduate certificate in nonprofit management and governance from Georgetown University McCourt School of Public Policy. Dr. Nanci Coppola will be speaking today on risk avoidance or sexual risk avoidance and risk cessation as optimal health for youth. Let's welcome at this time, Dr. Nanci Coppola.
Thank you so much for that wonderful introduction. I am going to share my screen with you all. As Sheldon said, I'm going to be speaking today on optimal health and sexual risk avoidance and cessation. And I want to just start with the concept of understanding that optimal health should be a right for all people and not a privilege for a certain chosen few. So as we look at the optimal health approach this morning, I'd like to take a look at this concept that perspective becomes reality. And we listened to Dr. Wagner this morning eloquently talk about how we should be wise in understanding what folks are trying to do. And so I give you this example of the blind men or blindfolded men and women who are trying to discern what this elephant is. And their perspective becomes their reality. For the first, on the far left, feeling only the trunk, it is a spear. Those feeling the toes fear that it's a snake. Someone behind the leg is implying that it's a tree. We have one who contends and professes that is a wall, one who views it and attests that it is just a rope, and finally another who believes it is a fan. We need to look at the entire picture so that our own perspective or the perspective that others are trying to put upon us do not become our reality. We must stop, think, and then act. And I would caution that when we act first without stopping and thinking, we are allowing others to lead the way. We cannot let others dictate what becomes our reality. And so I put these two very wise quotes here for you to just contemplate as I go through my discussion this morning. We should never let someone else's opinion of us or of what we believe alter our reality. We must quietly affirm that we will define our own reality from now on, and that definition is to be based on inner wisdom. So let's look for a moment at what an optimal health model tells us. It is a social, ethical, mental, emotional, and physical framework for health. This dynamic balance of our physical, emotional, social, spiritual, and intellectual health, which all people are entitled to have. In order to get there, sometimes we must go through lifestyle change. And that change can be facilitated through a combination of learning experiences that enhance awareness, increase motivation, build skills, and most importantly, through the cessation of opportunities that open access to environments which make positive health practices become the easiest choice for all people. So this optimal health approach, if we think about it as a target, and by the time I'm done, this target model will be ingrained on your brain. And the goal is to ensure that we move all people or maintain them in this center bullseye target of no risk. When we allow folks to move out to low risk or high risk, we are not promoting an optimal health model. And in doing that, we are not giving folks what they deserve. So what is public health? We have our definition of optimal health. Now let's combine that with public health. And the public health model is sort of a science and art of preventing disease, prolonging life, and promoting the health of all members of a community. So it is a community-wide approach, and we have had wonderful examples globally of community-wide approaches to a public health problem very recently with COVID. We have not just tried to stop this at the individual level. It has truly been a global and community-wide approach to preventing people from getting the disease rather than having to treat it after it happens. And so the work of public health is really achieved by promoting healthy lifestyles. If we look at a public health intervention, there are three different prongs to an intervention. We have a primary approach to the intervention, which is the optimal health framework. It is a risk avoidance approach where we prevent or delay illness or the high risk behavior. When that is not possible, and only when that is not possible, we take a secondary approach to public health, and that is using protection or risk reduction to reduce the consequences of illness or high risk behavior. If we use COVID as our example, wearing masks is risk reduction. Getting the vaccine to prevent is risk avoidance. Tertiary is treating the illness or the consequence of the high risk behavior. So after illness has occurred, we treat then the consequences. So it's clear then that primary prevention is the key to success. This public health approach then requires that we assess a situation, we develop policies to ensure a risk reduction approach, and then we measure the success of that approach. And if we need to take a new approach, then that is what we do. We look at, in a public health and optimal health model, this concept of surveillance and determining what the problem is. We identify the risk factor, what is the cause, and then we develop interventions to prevent. And then finally, we evaluate and determine whether or not this worked. So that first level, again, we said is intervention. And it is this primary prevention or risk avoidance. And the strategies are developed to prevent behaviors from occurring. So why should we promote primary prevention? I want us to think about what would happen if you are standing beside a river and you see someone drowning as they float by. You jump in, you pull them out, bring them to the shore to safety. And you're exhausted. But a moment later, another person floats by. You jump in once again, you pull them out, and another, and another, and another. And you continue to pull these people who are floating by, and you bring them out to safety. As exhausted as you were after you pulled the first, by the time you get to the 10th or the 12th, you feel like you can no longer go on pulling these people out of the water. So you decide that you're going to travel upstream and you're going to figure out what the problem was. That's our surveillance. What was the problem? So what you find is that there's a hole in the bridge. What do? Do you keep going back downriver and pulling people out? No. Logically, you fix the hole in the bridge and folks stop falling into the river because they aren't stepping on the hole in the bridge. Once that's fixed, you have taken a population-wide approach to resolving your problem instead of individually lifting people out from that critical issue. And so a public health approach means we go upstream, we find the problem, and we fix the problem at its source rather than dealing with the consequences of the problem. So why do we want to use this primary prevention approach? And is this a new approach? Clearly, in 1466 to 1536, lived the person who we would call the father of primary prevention. Erasmus said, prevention is better than cure. This concept has not changed. In the 1700s, Benjamin Franklin echoed that same sentiment when he said, an ounce of prevention is worth a pound of cure. And across the globe, many people are familiar with the work of Mark Twain. And in the early 1900s, Twain repeatedly said, it is easier to stay out than to get out of a problem. So primary prevention really takes us on this risk avoidance approach. And so I would like us to think about the fact that regardless of what the health problem is, whether the health problem is COVID, whether it's malaria, whether it's meningitis, it doesn't matter. If it is a sexual health education as the problem, it doesn't matter. A risk avoidance approach is always the best public health approach because it is an optimal health model. So let's take this concept of primary, secondary, and tertiary prevention, and let's apply it to sexual activity. When we attempt to apply this to sexual activity, we understand that prevention is the most reliable way to avoid sexual risk. We abstain from sexual activity or are in a long-term mutually monogamous relationship with an uninfected partner. And so we call that mutually monogamous relationship a marriage. That is prevention, risk avoidance. It is abstaining until you're in that committed relationship. And then once in that relationship, the B part of it is being faithful and maintaining monogamy. Secondary prevention would be a risk reduction model. And that has been referred to as the C of our ABC public health approach. And that is consistent and correct use of male latex condoms, which reduce the risk of sexual activity. So I want us to be clear. This never becomes primary prevention. It is risk reduction and protection because it does not eliminate all risk. And then tertiary care would be the treatment of sexually transmitted diseases and infections, as well as prenatal and postnatal care should someone become pregnant. So keeping that in mind, I want us to think about using an optimal health model to eliminate the soft bigotry of low expectations. And when I say that, let me just explain, because some people may not be familiar with this term of the bigotry of low expectations. When we say that youth cannot make healthy choices and they're teenagers and they are just going to engage in sexual activity anyway, so we should move immediately to that C or protection and teach them to have safer sex, because condoms do not make sex safe. They may make it safer, but they do not eliminate all risks. So when we say that youth are not capable of making the healthiest choice, what we are saying is that we're setting low expectations for them. And if we do not set low expectations for all youth, then we're engaging in this bigotry of low expectations. What do I want for my own child, as opposed to what do I want for other children? And we should all want an optimal health model for all youth globally. So let's look for a minute at what this risk avoidance model tells us. We're avoiding all risk and eliminating the chances of any of the negative consequences. So risk avoidance is truly the optimal adolescent health option because we are avoiding the risk, and it is superior to reducing the risk because it produces the fewest long-term health, educational, and social consequences. Health outcomes are typically improved when health behavior risks are avoided during adolescence. And I could talk for a couple of hours just on the risks associated with adolescent health, and that is not our focus here today. But if you are interested, I can share some information on that with Rebecca and Reverend Austin that they can share with you. The other important aspect to understand is that risk avoidance allows for optimal physical, mental, and social development of youth through self-management, which allows them to not only have optimal health in adolescence, but across their entire lifespan, because it builds skills that are beneficial to other tasks, such as their academics and sports. Now, we do know that when we're engaging with youth, not all of them are in that center of that bullseye that I showed you earlier, where they are at no risk. Some of them have already engaged in risk behaviors, whether through force, coercion, or by choice. And so a public health model then also works for recovery and restoration. In recovery, we improve following an illness or condition, and in restoration, we return to the status of low risk to prevent an illness or condition from reoccurring. And we will revisit these terms a couple of times as I go throughout my presentation this morning for you. So my question for us to consider as we move forward is, should the rules change here? For many in public policy, the rules do change. The sense, as I said, that these kids are going to have sex anyway, so let's make it safe without considering the implications. Despite anti-smoking and anti-drug campaigns across the globe, some youth get hooked anyway, and the "don't do it" message is still seen as the best one. Programs across the globe have not changed to teach youth how to use drugs more safely. If I were to come in to a department or Ministry of Education or Health anywhere across the globe and say, I think that you should run a program that is risk reduction for drugs. We should hand out clean needles in schools, and we should teach youth to use clean needles. We should teach them to snort drugs rather than use needles, because needles give them exposure to additional diseases. Folks would run me out of whatever country I dared to step in with that message. There would be no one in that room, regardless of how many people who were there, who were saying, oh yes, Dr. Coppola, that's a really good idea. They would ask me, what, when I had my mental breakdown and why I had decided that such a foolish approach might actually work. But when it comes to sex education, those same policymakers, those same individuals in those same departments across the globe are trying to tell us that a risk reduction message for sexual health education is the way to go. I would caution us to ask the difficult questions and ask them why they are engaging in the bigotry of low expectations. So if we look at our earlier approach to figuring out and surveilling, what is the problem? The issue is that when we look at adolescent sexual health, the way that the statement is being framed now is that unprotected sex has come to be seen as a health problem and as a barrier to educational achievement. And so the identification of the risk factor here, or the cause, is simply not using a condom. If we are honest about it, it is not unprotected sexual activity that is the barrier. It is the sexual activity, the early debut of sexual activity in adolescence, that should be viewed as the problem. So clearly, health promotion in general, and pregnancy as well as sexual transmitted diseases and emotional health prevention, are vitally important to healthy physical, emotional, and educational development of your nation's youth. However, what we have seen in countries where comprehensive sex ed is used, and the model is this, where unprotected sex is viewed as the problem, what happens is we have done a wonderful job of reducing teen pregnancies while driving up the rates of sexually transmitted diseases, of driving up the rates of emotional distress, of driving up the rates of adolescent depression and suicide. So we need to look at this much more holistically and much more globally. So the goal of prevention, we said, is primary intervention, to intervene with individuals before something happens. and to prevent the delay or onset of whatever the consequence or disease is. If we apply this then to adolescent health when it comes to sexual activity, we should be saying that we should intervene with individuals before they engage in sexual activity, delay or prevent the onset of sexual activity. Secondary prevention would be to limit the number of sexual partners and teach appropriate risk reduction options. And tertiary then would be to deal with the consequences of those who engage in sexual activity. And that includes, as we said at the beginning of our optimal health discussion, including their physical, emotional, mental, social, and intellectual health. So what are the best public health approaches for adolescents here? We have to support adolescents as they mature mentally, emotionally, socially, and physically. We must focus on risk avoidance as the first and most consistent message, not as an afterthought, not as a single page in a 300-page curricula, but as the primary and unambiguous main message must be a risk avoidance approach, and that must be consistent. We need to offer education and skills about the risks, whether those relate to drugs, early sex, alcohol, violence, and how to avoid those. And we need to recognize the importance of parents' values and traditions. We must not allow anyone to change the perspective of our reality and usurp our authority over these children. So how do we make this public health, optimal health approach model work? Optimal health, as we showed earlier, is no risk. So we start with those who are in a situation of being in no risk. And I'm just going to go here ahead for a second to remind you that this is the target that we're looking at, that green in the middle. So our goal here then is to give youth the skills they need to build resistance and resist pressure, because all youth deserve to learn the skills needed to achieve optimal physical, emotional, social, and intellectual health. However, some youth may be in a situation of low risk. And what we will do here is with youth who are engaged in risk behaviors, we seek to move them away from those risk behaviors. For those who are at high risk, we give them skills to cease those risk behaviors and return them to a risk-free lifestyle. If they need treatment for pregnancy or STIs, then that needs to be done. And we encourage them then to come back to a path of avoiding risk so that we are constantly revisiting this optimal health approach and moving youth from those outer rims of high risk to low risk to no risk. But most important, we should be focusing on those that are in this situation of no risk and giving them the skills to stay there. Again, we engage in the bigotry of low expectations when we assume that all youth will or are engaging in risk behaviors. And anyone who has heard me speak before in the past knows that when we look at the statistics of what youth are and are not doing in Trinidad and Tobago, the majority of youth are not sexually active. So if we are teaching programs that are promoting sexuality identification, experimentation, and sexual experimentation in terms of various activities, we are moving children to high risk instead of encouraging them to stay in this no risk situation. So how do these public health approaches work for youth and how do they benefit youth? A public health for adolescents must include, as I mentioned earlier, this recovery and restoration to help adolescents who have experienced the consequences of high-risk behaviors, and we encourage them and provide them with skills to return to risk avoidance. We have to encourage and support healthy choices from many sources. Youth should be getting a consistent message from their parents, from their community, from their school, and from the media. When we give conflicting messages to youth who have an underdeveloped brain, and that again is another 2 hours of discussion, but suffice it to say for now, for those of you who are not aware, the adolescent brain is not fully developed until 25 in women and about 27 in young men. They do not have the ability to understand how their choices today create consequences for tomorrow. And so we need to provide them with a unified message and support them through those difficult years of adolescence so that we are encouraging them and giving them the skills to make the healthiest choices. We must meet youth where they are. And so a sexual risk cessation model is used for any youth who are already sexually experienced. Because one of the things that we will hear from folks at the UN and in UNICEF is that a risk avoidance model doesn't work for those who are sexually active, but a risk cessation model does, and that is still an optimal health approach. And we cannot say that those who have been sexually active or those who are engaging in drug use or alcohol use should just be allowed to continue in that unhealthy behavior. We need to return them to a path toward optimal health. We would never say that we have a 15 or 16-year-old who has become addicted to drugs and, well, that's just what's going to happen and that's the way they're going to be. We would be intervening and trying to return them to a no-risk status, and we must do the same here. When we restore health and think about a risk cessation model, what we are doing is really ending a detour that has taken them off the trajectory towards optimal health. And whether they have gone this way, that way, or another way out of choice or because they were forced or coerced, we still can move them back on a trajectory towards optimal health. So I want to just stop here for a moment or two just to address this concept of force and coercion and why risk cessation still works there. So we need to talk for just a moment about the importance of consent. And while that's not the main focus of my topic today, I think we cannot leave this elephant in the room without talking about it. It's important for all of us as adults to understand what consent is and what it is not, because that provides for us a critical foundation for ensuring that sexual violence does not happen. And when we think about the importance of consent, we need to understand that what this means is that a person has given permission or agreed to something. And when it comes to sexual situations, consent means that all people in the relationship have agreed to and are comfortable with engaging in a specific sexual behavior, whether that be holding hands, kissing, touching, or having sex. And it also means that each person listens to and respects the other person when they say that they do not want to. What often happens is that whether by choice or by force, a young person engages in sexual activity for the first time. When there is not an understanding of consent, there is this misconception that because I did this once, I must continue to do it again. And we need to understand that consent needs to happen each and every time. And when we do not do that, then what happens is we begin to blame victims. The youth themselves don't understand their own limits, or they don't respect the limits of others. And this is how sexual violence becomes perpetuated, especially those who may be in a relationship. And make no mistake about it, that just because someone is in a dating relationship does not mean that there is not the possibility for intimate partner violence and abuse. So youth need to understand their own rights so that they can be better protected, so that they can report force and coercion, and so that they can make different choices moving forward. So suffice it to say that understanding consent means that consent must be free of coercion, it must be clear, it must be continuous, and it must be conscious. So that then takes us to a point where I'd like to change our trajectory a little bit now and talk about what a framework for sexual risk prevention looks like. At any point in time, adolescents can be at a different point on this continuum, and a continuum of change with secondary prevention needs to be distinguished from a continuum of primary prevention. Primary prevention is the choice not to have sex in those who have never been sexually active. We provide skills to continue making that healthy choice, that healthiest choice, and keep youth on a trajectory towards optimal health. In secondary prevention, they are choosing to not have sex after having initiated sex, whether that be, again, sex by force, coercion, or choice. And tertiary intervention occurs in those who are having sex and not willing or able to discontinue that activity. So how do we improve optimal health and move to lower risk? We first and foremost have to accept that cessation is a viable option, and we need to help the youth to accept that. We need to work with them to set healthy sexual boundaries, to communicate the decision to stop having sex, to seek peer and adult support for that decision. Sexual risk cessation then requires a belief or an intention that they can choose to discontinue sexual activity, that is a viable option for them. And again, not the main point of today's talk, but just, and Rebecca can attest to this, when you tell someone this, very often the response you get is, no one ever told me before that I had a choice. We would seek to decrease the number of sexual partners as we move someone back to a trajectory of no risk and decrease the frequency of sexual activity. Sexual risk cessation moves someone on trajectory towards optimal health because it is reducing the physical, emotional, social, spiritual, and intellectual consequences of that risk behavior. So let's look at this, aligning it with our optimal health model. The risk factor identified, we said, is sexual activity, not unprotected sexual activity. So we use a population-wide primary prevention model to say sexual activity itself is the risk factor in adolescence. So we must delay sexual activity, promote long-term mutually monogamous relationships such as marriage with an uninfected partner. And that is our primary prevention model. For those who have already had sex, sexual activity is still the risk factor that we identify. And so in order to move them back to no risk, we choose to help them to delay further sexual activity, to promote within them the benefits of delaying in that optimal health model and provide for them support mechanisms to help them make healthy choices moving forward. Risk reduction, not risk prevention, would say that the risk factor identified is having unprotected sexual activity. And so in those who are having protected sexual activity, we would ask the question, is not having sex an option for you right now? Because you can see that protected sexual activity is still a low to high risk behavior, and that is not where we want them to be. If it is protected sexual activity and it is consensual, it's still a low to high risk behavior. While some would say that confirming appropriate use of contraceptives and consistent use of condoms will reduce some of the risk, that is true, but we would also need to encourage testing for STIs, decreasing the number of partners, and moving them towards risk cessation. When it is protected sexual activity and coerced or non-consensual sexual activity, this is the highest risk behavior. And we need to inform people about unhealthy relationships. In these instances, you might need to involve social services to address the underlying root cause of that problem. When the risk factor identified is unprotected sex with multiple partners, this is an incredibly high risk behavior, and the focus needs to be, again, on moving them incrementally away from that risk behavior. So let's look quickly at optimal health in action. Here are all of those components of optimal health that we spoke of earlier: physical, emotional, social, spiritual, and intellectual health. Really working to move folks to no risk. It is important to, again, look at the parents here. What is the influence of parents, friends, and future goals? Youth who are moving away from a trajectory towards optimal health are very often in conflict with their family's values and their parents. It puts them at risk for physical, emotional, spiritual, and intellectual health problems, because many times it's the cause of dropout from school. So how do we improve health outcomes? We give teens a primary prevention message as it pertains to all risk behaviors, and because it gives them the best possible health outcomes. So improving optimal health, the answer to that question, how do we improve optimal health, is really pretty simple. We need to provide children with education, and then the question becomes, what kind of education will provide the best outcomes? The answer here again is very straightforward. We provide the type of education that produces the best outcomes for their emotional, physical, and financial futures. And that is a risk avoidance intervention, one that teaches them how to eliminate risks rather than simply reducing them. And so SRA programs are holistic programs that address teen sexual activity from the standpoint of recognizing the possible consequences far exceed just pregnancy and transmission of sexually transmitted diseases. It is their true whole selves that are at risk here. And so SRA provides teens with multifaceted information and skills that will help them avoid all of the risks associated with teen sex. And the end result is that we are providing youth with skills to wait to have sex, because that is easier and less expensive, because staying out is easier than getting out. And that is the best way for approaching our youth. Teens who avoid these consequences are far more likely to be successful in reaching their goals, more likely to succeed academically, less likely to live in poverty, and more likely to have successful long-term relationships when they do enter into them. Marriages are better in youth who have delayed. So our overall goals are really to reduce the risk factors to promote the protective factors of awareness, self-management, responsible decision-making, relationship skills, and social awareness. We must attempt to reduce low self-esteem, bullying, anxiety, peer pressure, insecure attachment, poor social and communication skills, emotional issues, family dysfunction, substance abuse, and early sexual delay in order to prevent poverty, isolation, disconnection, and low academic achievement, which then sets youth on a path of hope and a promising future. Prevention, as we started out here, is better than cure. Risk avoidance is primary prevention of all high-risk behaviors, and it needs to be seen as a vital part of promoting optimal health and public health education. That ounce of prevention has outweighed the pound of cure. The overall benefits of delaying sexual activity cannot be minimized. It is the healthiest choice. It provides physical, emotional, and social health benefits. It leads to healthy relationship formation. It leads to financial stability, and youth are less likely to become involved in other unhealthy risk-taking. I know that was a lot, and we did it really quickly, and we'll engage and entertain questions after the next speaker, I think. So for now, thank you so much for listening, and I will turn it back over.